Hello, everybody. You come into the space. Welcome to our webinar, our TFMR 101 webinar. We're going to go ahead and get started as people come into the space starting promptly at 12. I'm going to do a quick introduction. Hello, my name is Betsy Winter. And my pronouns are she, her, hers, and I'm the Director of Community Support for Return to Zero Hope. And I want to welcome you to this webinar on Termination for Medical Reasons 101. Before we begin, I'd like to share just a little bit about Return to Zero. Our mission is to engage a global community of bereaved parents and their health providers to improve mental health outcomes while also advancing pregnancy and infant loss awareness, education, and support. And at Return to Zero, we serve bereaved parents through direct services, such as our virtual support groups, workshops, and in-person retreats, through online resources and education, and by providing resources, trainings, and support to the providers who interface with these parents through their journey of love and loss. And because we believe helping providers helps families in the end, we have made many of our services and print materials free of charge to providers. To learn more about our services, you can visit our website at rtzhope.org. And while you are there, please consider making a donation, as we are a 501c3 nonprofit and rely on the generosity of our donors to continue to do this important work that we do and that you all do as well. So today's webinar is the first in a three-part series covering the important topic of terminations for medical reasons in a post-Roe United States. And at Return to Zero Hope, we recognize the significant and traumatizing impact that politics, law, religion, and culture have on individuals and families needing access to reproductive health care, specifically abortion and termination for medical reasons. And we are committed to creating spaces and providing resources that honor the diversity of humanity and all forms of loss experienced during our pregnancy or parenthood journeys, including the full spectrum of reasons for terminations. And I'm really excited to introduce the lovely Jane Armstrong this afternoon, who will be presenting not only today, but throughout this three-part series. Jane is a TFMR mom, native Texan, and she is also a clinical social worker certified in perinatal mental health. And following the birth and death of her first child, Frankie, through termination for medical reason, Jane opened Both and Therapy to provide individual therapy and support groups to other TFMR parents. These services aim to support parents through the unique barriers and grief of ending a wanted pregnancy, particularly in the state of Texas, where such care is no longer accessible. She's passionate about building community, eliminating shame, and honoring grief for TFMR families. And it's a real honor to have her here today, offering us this webinar. So thank you, Jane.
Thank you. I'm so grateful to be here with all of you and dive into this topic today. We're going to be getting a real baseline foundation set about what termination for medical reasons is, things to consider in the unique experience of loss that these parents go through. And I'm really grateful that y'all are here. To start off, we're gonna poll those of you who are tuning in live today, just to get a sense of kind of where folks are with understanding termination for medical reasons. So you can either scan that QR code in the bottom left of the screen, or if you prefer to go into your browser, enter that link and the code you see there, and tell me on a scale of 1 to 5, 1 being not a thing, here to learn all the things, and 5 being I already know quite a bit, but I'm interested to know kind of what someone considers a 101 level knowledge for TFMR. We're going to go through quite a few things today, beginning with me telling you a bit about myself and what brings me to this work. Thank you, Betsy, for that context as well. We're going to dive into what is TFMR, some common diagnoses that lead families to terminate for medical reasons, common screening and diagnostic tools that are used in pregnancy, how these things are detected, and then moving into towards the end of our time, a Q&A period as well, so that folks can ask any questions that you have with you today. All right. Thank y'all for putting in some of your responses to our little poll here. We've got a bit of variation, which is always great. That means hopefully we'll have a really rich Q&A session at the end. So that's going to stay open. If you're still adding your stuff in there, please feel free to keep doing that. And I'm going to switch over to my slides here. All right. And let's see. All right. I hope someone will holler at me if you can't see what slides I'm sharing. So you should see our agenda for today. And since we've covered that, we're going to move on and tell you a little bit about me. So I am Jane. I use pronouns she, her, and I'm the founder and therapist at Both And Therapy in Texas. You can also find me on Instagram at TFMR Social Worker. I'm a licensed clinical social worker and board approved clinical supervisor. I'm also certified in perinatal mental health. I facilitate PSI's TFMR support group and have a background before this work and experience with agencies working with folks living with HIV and AIDS and public school students and their families. In my current work, offer individual therapy virtually to folks all over Texas, as well as support groups for primarily folks in Texas and other states where access to care is limited or impossible, but open to anyone, anywhere. And I'm personally based in the Austin area. So that's my professional background with a rather glamorous, windswept photo, professional headshot of myself, if I do say so myself. And I'm also here to provide a personal perspective to today's topic. As Betsy mentioned, I am a TFMR mom myself. As many of us do, I found my way into this work through my own personal experience. My husband Will and I, who you see there with our goofy dogs, Wally and Opal, got married in 2019. We actually just had our 4th wedding anniversary. And about a year later, we were really, really excited to find out that I was pregnant. Everything started out well. We found out we were having a boy. We named him Frankie and eventually announced around week 14 or 15 with a very unusual snowstorm that you see pictured in the middle there. This was early on in 2021, the first of a few weird winter storms that year. Shortly after that announcement was made, a slightly elevated blood test at my regular 16-week appointment led me to an MFM appointment for an early anatomy scan. MFM is a maternal fetal medicine specialist. They're usually the ones in there with any high-risk pregnancy. And in that anatomy scan, it was all bad news, and our world was shattered. We went through an amniocentesis and some referrals to fetal surgeons and other specialists to try to help us understand what was going on. with our baby and with our pregnancy. We learned in that anatomy scan that Frankie had myelomeningocele spina bifida and many, many related issues in his structural development. Many of these issues were going to have an impact not only on his physical capabilities, but also potentially cognitive issues and a spectrum where the doctors could not tell us exactly what we could expect for him, apart from a lot of medical intervention from the time even before he was born. With all of this swirling around us, we were presented with a decision. Did we want to continue our pregnancy and go through all of the related medical intervention, or did we want to end our pregnancy? This was an absolutely heart-wrenching decision to be handed to us. Something I experienced and hear from many other TFMR families is how much I wished somebody could tell me with any certainty what was going to happen on either of these paths chosen, but nobody could. We were at the time in Texas before SB 8, a law you may have heard of referred to as the bounty hunter law, and pre-Dobbs. So Roe was still in effect at the time. And in Texas, for a fetal anomaly, we had up until 21 weeks and 6 days to end our pregnancy. I had my anatomy scan at the absolute earliest moment I could in my pregnancy, which had me at 18 weeks and 3 days. So we did not have much time at all to really weigh things out. And it felt like there was a very loudly ticking clock hanging over us all the time. Long and very complex story short, given the choice for our Frankie between life and peace, my husband and I chose peace and decided to end the pregnancy. We were able to do so legally close to home, which is not an option available to TFMR parents in Texas anymore. And Frankie was born and died via a D&E at a Planned Parenthood over 3 days of appointments. There was a freak snowstorm in there. You may have seen Winter Storm Uri on the news, where millions and millions of Texans lost power. We were among those, and that actually delayed my procedure by a week. So Frankie and my pregnancy, we were 21 weeks and 3 days when he died. So just barely under the limit at the time in Texas. This was back in February of 2021. And we were able to get one footprint that I'm so grateful to the doctors at Planned Parenthood for. You can see it there at the bottom right with his birth date on it, and next to the feet of our living son, Nolan, who we were so grateful to bring home healthy last summer following a second anxiety-riddled pregnancy. As a part of my grieving process and in a desperate search for community, I scoured the internet for resources, including the incredible support groups offered at RTZ Hope. I got some tattoos, I got my PMHC, organized in-person meetups for some local TFMR parents, started facilitating PSI's TFMR support group, created my Instagram profile, and shifted my entire career in order to focus my skills, training, and passion into supporting TFMR parents in Texas so that they could have the support that I was missing at the time. I really want to thank you for letting me share this part of my story with you, and it means a lot to me, both as a bereaved parent and as a professional, that you're all with me today to learn more about TFMR. So thank you. All right. So what is termination for medical reasons? TFMR, we hear this all the time. TFMR just means someone who has ended a wanted pregnancy due to their own health or the health of their babies. Emma Bell of TFMR Mamas has a beautiful quote. It is a decision made with the most love and the biggest heartbreak. And you'll see those quotes around decision. Language around TFMR is very layered, complex, and individual. Sometimes folks really struggle with the word decision. Many kind of recoil from the word choice, even in looking at a pro-choice movement, or that they chose for their baby to die. These are really complex and layered things that we will dive into a bit more together now. So, some more definitions and language. Termination for medical reasons, or TFMR, is not a medical term. It's not something that you'll see in anybody's chart. And it was actually born on social media. This was a term designed to help these parents build community and connect with one another. TFMR is not always given the respect and inclusion that it deserves. So it may sometimes feel like the black sheep, whether it's of the baby loss community or of the abortion debate. TFMR stories are often not centered or often included in some of these spaces, despite TFMR parents being members of those communities. In medical charts, you'll often see either terms about elective abortion. You may see surgical procedures outlined, such as D&E or DNC, and we'll talk a bit more about those in just a moment. But these medical terms, again, can often prickle a lot of bereaved parents. Often with miscarriage, you'll see spontaneous abortion in charts, and miscarriage parents will often talk about how they find that shocking, because in our society, abortion is a very charged, very political term, despite being a medical term. With this presentation, I will use some different terminology throughout. Mostly this will be termination for medical reasons, TFMR. You'll also potentially hear me talk about abortions. These are linguistic differences that I make intentionally. I do want to make sure we're focused on the TFMR experience and really diving into that foundational level of what it means to go through a termination for medical reasons. And every step along the way for TFMR parents is impacted by laws that limit abortion. So when we talk about abortions, we need to be talking about termination for medical reasons. That's not to say that if you're speaking with a parent, that you should impose language on them. But if we can use this moment talking about language just to remind everyone to reflect the language that parents choose for themselves. So whether they talk about the birth of their child, the procedure they went through, their abortions, we want to make sure that we're using that term back to them. When it comes to termination for medical reasons, knowing this term can really open up opportunities for parents to find community resources and services that are really geared towards them. I remember shortly after my loss, sitting down at the computer, opening Google, and literally not knowing what to type. I knew if I typed abortion, some really scary stuff would come up that was not what I needed to see at that moment. But I didn't know the words to use for my own experience until I found termination for medical reasons and the TFMR community online. Some common reasons for termination for medical reasons. Typically, you'll see either fetal health conditions or the health of the pregnant parent. Sometimes these can be overlapping and involve one another as well. We're going to go into some of the most common diagnoses that you see in the community. This list is meant to be an overview. And again, we're in a 101 level right now. This is not exhaustive. There are about as many different TFMR experiences and medical diagnoses as there are TFMR families. So these are just some of the most common ones that you'll find in TFMR spaces. So when we think about fetal health conditions, it's often broken into two, either a chromosomal or genetic abnormality or structural issues. In chromosomal and genetic abnormalities, you may see trisomies. This is when 3 chromosomes rather than the usual pair appear in the DNA. So for example, Down syndrome, which is trisomy 21 or T21, is called so because there are 3 copies of chromosome 21 instead of 2. You see a few different trisomies there. Bilateral renal agenesis is also a chromosomal condition. This is where the kidneys fail to develop. And these genetic issues can be related to one or both parents being genetic carriers, as well as being what many TFMR parents frustratingly hear referred to as fluke incidents with no known cause. So you'll often hear about things being, a 1 in a 500,000 chance, a 1 in a million chance that something like this could happen. And it's now happened in this person's pregnancy and risked the health of their baby. Something to think about with any of these fetal health conditions, especially ones where there is not a known cause. A lot of these parents really struggle in future pregnancies or trying to conceive again, because even though the statistics might say it's highly unlikely that something like this would happen again, the highly unlikely to happen at all has already happened to them. So often TFMR parents do not find comfort in statistics because they've been on the wrong side of them already and been through some really tough stuff. Over to the structural abnormality side, we have neural tube defects, things like spina bifida, like Frankie had, anencephaly. Heart defects, often you'll see things like hypoplastic left heart syndrome, hypoplastic right heart syndrome, and then brain defects, such as agenesis of the corpus callosum and many, many others. Like I said, we're not going to go too far into a laundry list of these, especially since I'm not a doctor or a diagnostic professional. But just to give you some context for the kind of news that folks are getting in their prenatal care and the limits of some of this information. So many of these diagnoses are typically detected around 10 to 12 weeks, so towards the end of the first trimester, around 20 weeks or about halfway through pregnancy, or less commonly into the 3rd trimester. I'd like you to keep these timelines in mind as we look ahead, especially when we connect this to the legal and political landscape in the United States post-Roe and post-Dobbs. These are not conditions that can be seen, diagnosed before many of the gestational limits you'll see across the country in states where abortion is still legal and accessible, unlike Texas, where it is not. Speaking of these prenatal care tools, I want to look a little bit at some common screening and diagnostic tools that folks interact with during their prenatal care. Once again, I'm not a doctor, so this is not medical advice or interpretation. This is just giving some context for what some of these acronyms, common tests might be, and how they are thought of before and after TFMR. So NIPT, or a non-invasive prenatal test, is often the first of prenatal tests that will be offered. This is a screening tool, so it is not diagnostic, but it can flag risk for certain genetic abnormalities for further testing and diagnostic testing. This is where they take a pregnant person's blood to detect those congenital abnormalities in baby's DNA, which is in the pregnant person's blood. Very high tech, very cool stuff. Most people going into the NIPT are thinking of one thing. It is not typically getting flagged for risk for any of those trisomies we saw or other issues. They're taking that test so that they can find out the sex of their baby. And since we're looking at DNA in these tests, that is available. So for many of our TFMR parents where there is a genetic issue or chromosomal issue, this may be the first indication that something may be wrong with baby's health or in their pregnancy. This is also potentially the first place where somebody may turn to Dr. Google and see a lot of stories out there around false positives on NIPTs, things where doctor said one thing and we were told something awful was going on, and now we have this perfect, healthy, living baby. So there's a lot of folks looking for reassurance when something is flagged in an NIPT. And there certainly are times where a diagnostic test shows nothing wrong, but NIPT is usually happening towards the end of the first trimester. So I think typically between weeks 10 and 12. Then we have an NT scan or a nuchal translucency scan. This is typically performed on a similar timeline and often used in line with NIPT results to see how likely any flagged risk is showing up in baby structural development. So this is using an ultrasound that measures the thickness of the nuchal fold, which is tissue at the back of baby's neck at this phase of pregnancy. A larger measurement there can potentially indicate issues, including some of those genetic conditions and chromosomal abnormalities we talked about before. A CVS or chorionic villus sampling would be the first kind of diagnostic test available for folks. This is where a sample of tissue from the placenta is taken and tested for chromosomal abnormalities. So that placenta will have some of that DNA from baby. And this is usually available in that same window towards the end of the first trimester. We also have amniocentesis, so a CVS or an amnio, as it's often called, are two of those diagnostic tools. So this will actually give a diagnosis, not just a level of risk for different diagnoses. This is where a sample of amniotic fluid is taken from around baby in utero, and the fluid is tested to see if baby has any of these health conditions that can be seen with an amniocentesis. And then finally, we have ultrasound. This is a very common prenatal care for imaging. Some pregnancies may have very few of these, others may have much more frequent ultrasounds. It depends very much on what's going on with health or risk factors in mom and baby, in the pregnant parent and in baby. But many of those more structural issues are often first indicated in an ultrasound. Now, there are loads more potential diagnostic and screening tools. For example, there can be MRIs done while baby is still in utero. There can be echocardiograms to have a look at their heart. Loads and loads of other things. These are just some of the most common where there may be a first indication that something isn't right with baby's health. There are also several screening and diagnostic tools that may catch issues with the pregnant person's health. So common in prenatal care, there would be things like glucose testing, looking for gestational diabetes risk, or blood pressure, things like that. The health of the pregnant person can also have nothing to do with pregnancy at all. We have parents in our community who have received cancer diagnoses in the middle of pregnancy and are looking at, how to balance their own life and baby's life. Is baby's life at risk regardless? Things like that. So it does not have to be a pregnancy related health issue to be a part of this community. There are also, going back to our fetal health conditions, these screening and diagnostic tools are great for the fact that they give us information, and there are limits to the information available from them. So when we look at what this means for families getting this news, is that many of these diagnoses and many of these diagnostic tools lack certainty. It is typically unusual that a doctor can give a definitive answer as to whether or not a diagnosis is ultimately fatal for baby. If they can give a definitive answer on that, they likely can't tell you when or how that may happen and how it may impact pregnancy. Fatal diagnoses with baby are often called incompatible with life. You may also hear non-viable pregnancy. These things are, like I said, even though it may feel like there's some level of certainty that this diagnosis is fatal, there's no telling if the pregnancy would continue for a week or for 4 more months. And sometimes there can be risk to the pregnant person when continuing pregnancies with some of these conditions. Non-fatal diagnoses bring in whole other layers of complexity to this issue. So if a diagnosis is not fatal, you may often hear this described as a life-limiting diagnosis, a spectrum. You may hear it referred to as a gray diagnosis. That spectrum can be between mild and completely unnoticeable up to completely incapacitating. Parents or doctors will not typically know the extent of the diagnosis's impact on baby's life until after birth. Sometimes, if there's a likelihood that baby will live beyond their first year, it may be up until their first birthday before the true impact of that diagnosis is known. Many TFMR parents describe that lack of clarity or lack of certainty from medical providers as a major stressor in the process of making decisions about whether to continue or end their pregnancy. There's a bit of a gap between the screening and diagnostic tools available and knowing the impact of that information. So if it were, we have this issue and there's this quick and easy fix, no sweat, and they'll be healthy, great. But that is typically not the case, even for some pretty intense and very impressive medical intervention that is available today. Another thing to consider is that OBs and MFMs who are often diagnosing these conditions do not have expertise or experience into details of prognosis of a huge array of potential fetal diagnoses. These doctors care for pregnant people during pregnancy. They're not caring for infants and children living with these conditions. So they often may not be able to give much context at all for the impact of those diagnoses on their patients or their babies' lives. That means that that may fall to other medical professionals, such as genetic counselors, fetal surgeons, and specialized pediatricians who may be able to provide more, but only if patients are referred to them or if they are relevant. So, for example, in my own experience, Frankie's diagnosis was not related to a genetic condition, so I did not meet with a genetic counselor. I did meet with fetal surgeons, but that might not have been appropriate for somebody else with certain genetic conditions showing up. This can be really frustrating for parents because often they just want someone to tell them what to do or what this diagnosis means so that they can have a clear direction to go and take their decision making. There's a drive to make an objectively correct decision in a circumstance that does not lend itself to any certainty or definitive outcomes, which can be very, very frustrating. Moving into maternal health conditions or health conditions that may impact our pregnant parents. So physical health, this can look like hyperemesis gravidarum or HG. This is something that came a bit more into sort of public consciousness when Princess Kate, Duchess of something, I don't remember where they're Duchess of now, but Prince William's wife, she in all of her pregnancies has experienced HG. Sometimes this is described as severe morning sickness, and I think that does a great disservice to people who have suffered with HG. What this might look like is parents routinely going to the ER for dehydration. It can lead to starvation. This may look like throwing up several dozen times every day. So this is not just feeling a little extra queasy than other pregnant people might be feeling. It can very well be a life-threatening condition. Preterm premature rupture of membranes or PPROM. So this would be somebody going into labor before baby is viable. This is a maternal health condition or a risk to the pregnant parent because there's a high risk of infection at that stage once the membranes are burst. And it reduces the amniotic fluid, which means baby's lungs may not develop, and a whole host of other issues. As I mentioned before, there can also be unrelated medical diagnoses such as cancer that pop up during pregnancy. Another thing with the health of the pregnant parent that's important to consider is mental health. I often like to talk about the layers of shame and the layers of stigma that come up in termination for medical reasons. I would say you have under the fetal health umbrella, there's fatal and non-fatal diagnoses and some different layers there. With the health of the pregnant parent, we're talking about fatal and non-fatal. We're also talking about physical versus mental health. There can be a lot of extra shame and stigma if a pregnancy is ended because the pregnant person was experiencing severe pregnancy depression or anxiety where their life and health were at risk. This is something that's really important to consider when we're creating spaces for termination for medical reasons, is that we want to be abundantly clear who is and is not welcome and who is and is not accounted for in the community. And we need to make sure that we're including those who have ended their pregnancies for their own health and those who have ended their pregnancies for their mental health, because their life matters and their loss matters. Okay. So if we get to a point where a family decides that ending their pregnancy is the least worst option, how does that happen? This is something that I think generally there's a lot of mystery around, due in large part to the intense abortion rhetoric in politics and law today. There can be a lot of vivid imagery planted by anti-abortion movement and rhetoric that comes to mind when we think about these different procedures. That can instill also a lot of extra fear in parents as they go in and present for care. Just like in the last slides, I'm going to remind you that I am not a doctor. So if y'all, when we get to our Q&A, if you have questions about this stuff, please ask, but just know I might not be able to answer. But we're going to look at some different methods for ending a pregnancy. Typically, folks fall into either a surgical termination or a labor and delivery. Beginning with surgical, we have a DNC, that's a dilation and curettage, which is most common in the first trimester. This is also typically the same procedure that someone who has a miscarriage with that is incomplete, where there's tissue left in the uterus, endangering the health of that person. It's the same procedure. A D&E, which is more common in the second trimester, is called a dilation and evacuation. Both of these are common and safe medical procedures. Typically, these are framed in anti-abortion rhetoric as very dangerous and risky procedures. And that was true when abortion was not legal and people were accessing care in very questionable circumstances out of desperation. In a clean and well-trained hospital setting or clinic setting, these are actually less risky to the pregnant person's health and fertility than a full-term live birth. So that can be something that many people do not know when presenting for care. Both of these procedures typically only take about 10 to 20 minutes. And depending on gestation, it may involve medication to soften or open the cervix, placing laminaria to do the same. This is small rods of a seaweed that expand, that can be placed in the cervix to soften and dilate it, usually the day before or potentially the day of. And typically it involves at least sedation and local anesthesia, though sometimes general anesthesia may be available. That is hugely variable from setting to setting. So these parents may or may not have much say in how much sedation or anesthesia they get. I remember for my own procedure, I was very eager for full anesthesia. I wanted to go to sleep and not be aware or awake in the room, and that was not available to me. I had sedation and local anesthesia instead, because that was all that was available at the clinic where I went for my procedure. With a surgical termination, it is also not always possible to see or hold baby's remains. This is something that a lot of folks may struggle with if they go with a surgical termination. Sometimes it may be felt a kindness to themselves in the moment not to meet their baby or have keepsakes. Sometimes it may be the only thing available to them. And that piece of surgical termination where you may or may not be able to see your baby or spend time with them is something that a lot of TFMR parents can struggle with at times. Looking at labor and delivery, this may also be called induction or compassionate induction. This is just inducing to initiate labor, just like you would with a full-term healthy living baby. This is more common over 24 weeks gestation, and like with any labor and delivery, it may take hours and or days. Sometimes baby's heart may be stopped with an injection through the abdominal wall prior to induction. This is also sometimes available during surgical procedures. The medical terminology for this is feticide or a KCL injection. When we talk about triggering or traumatic language that may show up in medical records, feticide is one that many parents really struggle with seeing in their chart. With a labor and delivery, parents will typically be able to decide whether or not they'd like to see or spend time with their baby's remains, just like they would with any other birth, whether a living birth or stillbirth in typically a hospital setting. When looking at the differences in these, I say available options, we're going to talk in a moment how they're not always available. But this can be another sort of impossible position to put really distressed, about to be grieving parents into. You cannot know going in what things are going to be like. For many TFMR parents, it may be their very first pregnancy that they're ending, and there may be some fear around labor and delivery or stress around not wanting their first experience with labor and delivery to be with a baby that they know is not going to survive. Surgical termination may be faster in terms of availability or timeline, and that may be attractive in ending the limbo between the decision of ending a pregnancy and actually ending it. That in between time, that purgatory, as it's often referred to, can, for many TFMR parents, be the most distressing part of their experience. So when we look at these two options, it may seem like it means that options are available. However, different methods of ending a pregnancy are not equally available to TFMR parents. How a parent gives birth is often more a function of their accessibility to care than it is a function of their preferences or best interests. So let's take Texas as an example and my own experience. I did not know until long after my loss that I would have even had an option to labor and deliver. It was not presented to me at the time. So that means I found out after the fact that other people had very different experiences than my own. Some folks may not have the option of surgical available to them where they are, and perhaps that would be the better option for them, or again, the least worst option for them at the time. Accessibility to these different methods has to do greatly with state law, where first and foremost is abortion at all legal, what gestation limits are in place, what medical professionals in that state or area have training to do these and offer them. Like I said, these are not, if you're in an OB specialty, you're a surgeon. Doing a D&E or D&C is not a next level surgical procedure for folks to learn, but if they're in a state unfriendly to abortion, they may or may not offer it to their patients in order to protect their licenses, their practices, and their patients' confidentiality. Availability of hospital policies that allow these things. Many hospitals and hospital systems may be religious organizations that do not allow their staff to perform abortions. I would say that most people, if it were available to them, might prefer to deliver with their own doctor, whether surgically or induced, but most do not offer that to their patients. So you may be meeting a doctor for the first time, going through this loss. Something else to think about after labor and delivery or surgical termination. TFMR parents are still postpartum. This is something that gets missed far too often, and I cannot say it enough. This goes for any kind of pregnancy loss, and I think often the added step of intervention in TFMR sometimes has parents even further removed from the idea of postpartum. So many TFMR parents are not adequately prepared for the postpartum period following their loss. They will still experience all of these things: the hormone drop, night sweats, hair loss, their milk may come in. They are at a higher risk for perinatal mood and anxiety disorders. And postpartum care after TFMR typically involves a single follow-up visit that may take place in person or via telehealth or the phone. You may possibly have two of these if the provider of your termination and your regular OB are two different people or operating in two different settings or systems. And for parents who have never been pregnant before, this can leave a huge gap in their care, especially as acute grief mixes with the hormone drop and the other physical changes they're going through at the time. So this is extra important to think about when we're talking about our TFMR parents. I see some of our time winding down, so I'm going to get to just a couple more slides and then we'll open up for our Q&A. Some things to think about when we're looking at surgical versus L&D are some unique issues of guilt and shame that may come up for TFMR parents struggling in their loss. There are all across the country, for most people with uteruses in the United States, medically unnecessary barriers to care. For my own experience, my nurse had to read a state mandated paragraph to me that contained a lot of false information, which she then had to backtrack and say, this wasn't true, this wasn't true, this wasn't true. It makes medical care feel really frightening to not know who to believe and to really see the politics and politicians showing up in the exam room with you and your doctor. If you're at an abortion clinic versus at a hospital setting, typically the patient must present alone for consultation and procedure. Typically, this is to protect patients from coercion and for medical staff to ensure that it is, in fact, that pregnant person who wants to end their pregnancy and that they're not being forced. However, for TFMR parents, this means that in pre-op and recovery, they will be alone, and any support people may be in a parking lot, or if during COVID, like my husband in a waiting room, and then my husband and many others in COVID were in the parking lot throughout, connected only by a phone. Signing the paperwork, consenting to care can also be an issue for TFMR parents that comes up for them in their loss. And then they must physically present for their procedure as well. So this can lead to lots and lots of those layers of stigma and shame that we were talking about before. So when you think about TFMR, I encourage you to think about these different layers and ways that you can make spaces more inclusive, more welcoming to TFMR parents, specifically by calling them out directly. And if you operate in a baby loss space, use the term TFMR. Make sure that folks know that they are welcome. Make sure they know they're welcome if it's for their own health or their own mental health. And those spaces become safer and safer and safer for our parents and hopefully for our baby loss community at large. So thank you so much for sticking with me through my slides. I'm happy to take some questions. You can either drop things in the chat, or I'm not sure if folks can unmute themselves, but Betsy, maybe you can tell us more if there's another option.
If you'd like to speak up, you can raise your hand, I believe, and I can allow you to talk as well.
Sweet. All right. I'm going to stop sharing too so we can see each other.
And real quickly, I just want to offer, Jane, thank you so much for that presentation. Even someone who thinks I am somewhat versed in this topic and have my own diagnosis as part of my story. It is just really a complex, layered situation that is unnecessarily made even more complex and more layered.
Yes.
What a service for you to provide to providers out there to really understand this very important topic that is such a reality for so many families. So thank you very much.
Thank you.
I'll also offer that we will be doing a part 2 and 3 of this series, where I believe Jane's going to be going a little bit deeper into maybe even looking at some of the politics and legality and laws around abortions right now in a post-Roe United States, and how that impacts most likely many of the people you work with and even the work that you might be doing.